Well, thank you all for having it today. So a little bit about me, just for those who don't know me, my training took me from New Mexico to Georgia, back to New Mexico. So I spent a total of 9 years there at a rural state doing pediatric palliative medicine for about 5 of those years. I also did adult palliative medicine on an inpatient basis and some clinical ethics. And so I can kind of speak to like a wide range of things. Today, though, I'm just going to really focus on kind of what work that I do and what we do to serve the community. So for some of you, this may be a little bit redundant because you might know what we already do. But, Dr. Dahlberg talked about the services that we have at Children's Minnesota, which is where I'm one of the pediatric hospice and palliative medicine physicians. And so I want to touch on those because at Children's Minnesota, we are the only dedicated and pediatric-focused hospice in the state of Minnesota. And like in New Mexico, where at the University of New Mexico, we were the only pediatric hospice, we service a very tight area. We work very closely with Crescent Cove. But we want to, with our work at Children's and through the coalition, expand what services we can provide and what access we can give to children across the state. So at Children's, we have our Pediatric Pain, Palliative Care, and Integrative Medicine department. And through there, we have our Pain Functional Rehabilitation Clinic, which is our chronic pain department where we focus on trying to treat children's pain exclusively. And then we have expanded those clinics to include neonatal abstinence, and then that has broadened even further to the Tapers Clinic. And then we have our hospice and palliative medicine team, of which I am a part of, and then our integrative medicine team, and I'll touch on all of those little resources for all of you. So our pain and functional rehabilitation clinic is a team that is outpatient only. We do sometimes see children in the hospital, but really primarily focus outpatient to reduce the suffering related to chronic pain states of really any condition. Some of these are pain syndromes. Some of these are children who are experiencing pain all of the time, but don't have a formal diagnosis. And we work to support those children outpatient as best as possible. That team, I know Dr. Dahlberg again did a huge job like outlining how many people are on each team, so some of this is a little redundant. But there they have one physician and one nurse practitioner. Dr. Schwartz actually, who Jody has alluded to, came from Gillette and is now the head of the chronic pain and functional rehabilitation booth. Dr. Schwartz also does some acupuncture and maybe some kind of interventional pain techniques. And so we would say that if you have any needs for any children anywhere across the state, we're happy to try to do our best to see patients there. But we're not really here to talk about chronic pain, so you should know that that exists. What we really want to dig into is what does hospice and palliative care look like here in the state of Minnesota. And so through our team, we try to meet children really wherever they are, right? Because that's the goal of palliative medicine. And really for hospice, the mission is to provide services to people who have a life-shortening diagnosis wherever they call home. And home for children looks a whole bunch of places. Home for some children might be their actual home. In the COVID pandemic in New Mexico, home for Native American populations was not their home because dying in the home where someone could not then cleanse that spirit from the home traps that person in the home until someone could come by and take care of that. Home might be for another patient of mine who was dying in the PICU, but their home was the 6th floor of the Children's Hospital because that's where they spent most of their time. And so we try on our team to service those children wherever we can and provide the services to them. And so on our team, we have a consultation service that's inpatient. We do 24-hour call. We're inside the hospital Monday through Saturday. But we are happy to take calls from anybody. And I think that I want to stress this now, rather than moving this to the hospice piece. For anybody who has worked with our team from a hospice perspective, we will work very diligently to build a hospice plan of care that involves an outline of their goals of care, an outline of their pain and symptom management recommendations, what has worked, what hasn't, and to work collaboratively with you outside of the hospital. Because we understand that like was just talked about, people feel uncomfortable with children suffering and children dying. And so for someone to say, I recognize that we should do the best work, but I am ill-equipped. I don't know the doses. I don't know how to help a family. I don't know how to do concurrent care billing. That is where our team is happy to answer a question any day or night. And so our job is focused on any disease that any child could have. So it's not necessarily a life-shortening diagnosis. People with sickle cell disease live wonderfully beautiful, long and happy and healthy full lives. But we will get involved with them because we understand that there's suffering associated with each of those admissions, not only from a physical perspective, but psychosocially, emotionally. And so, there we go. To expand the reach that we have for children, like I said, the Neonatal Abstinence Syndrome Clinic has expanded to really focus on how do we provide deeper support for children all across the state. So if we have someone who goes home on a medication or is in the hospital for a long time and a lot of medications, we will support them outside of the hospital to wean off of those medicines. And if we are unsuccessful, we transition those to one of our clinicians in the palliative medicine clinic to try to help get those kids off of the medicines as safely as possible. But again, children are not just the children that are alive yet. That's an asterisk there. We know that children have issues before they're born, right? We know that expectant mothers and expectant families might get a diagnosis in utero. That would be very concerning and maybe impact the ability of that child to survive through birth, or the amount of time that they might have after birth is very short. And so we have worked closely with the Midwest Fetal Care Center to offer perinatal palliative medicine consultations actively, and will often follow those children, those families after birth to build either palliative care plans or what have you. But this is the meat and potatoes, right? We can talk about all of those other things another day. We can sit and chat about those, you and I. What does hospice look like? What does home look like? So our home services service 30 miles around either of the children's hospitals, either the one in St. Paul or the one in Minneapolis. What I've learned recently is that that's like as the crow flies, which we really will sit down and try to beg one another to, hey man, this person's like 29.7 as the crow flies. That's 45 to get there, but like that works, right? Because our job is not to make our lives easier. Sorry to Cassin, who's not going to the audience. Our job is really to meet these kids where they are. We have a patient who is both in and out of our service area. And we worked collaboratively to sit down and say, how do we service this family? How do we make sure that they have all the resources that they need? Because what this family wants is to stay home. And how do we help them stay home the best we possibly can? We have 4 physicians on the team. We have 3 or nurses in the home. I almost missed once, right? We have a child life specialist. We have a spiritual care specialist here with us. And really our job is to add that layer of support. We work alongside home nursing companies. We work alongside D&E companies. We will do whatever we can to meet these children in the home. Telehealth. We will do home visits, however we can. Because we recognize that these children need that support. Integrated medicine is another consultation service that we had access to, which is trying to build, I like to phrase as non-pharmacologic ways to treat and manage symptoms and suffering at any stage of illness. This is done both inpatient and in a clinic base. And oftentimes, we can work collaboratively. I have a patient who will come and see me in person every once in a while, and we'll actually line those visits up with integrated medicine so that one family doesn't have to move from room to room. The provider will go from room to room. But that's great. That's what we do at Children's. That's fantastic. What about at the Coalition? So the Coalition, I'm newest to the team. Jody was the one that was spearheading this for a long time. And I've only recently come in and have been trying to find my way here. And our job is really to represent all of you. Our job is to represent the families. Our job is to advocate as best as possible. And what we're really actively trying to do is identify where those gaps are. Where are the missing pieces to provide this child, this one instance of hospice needs? How do we fix that for someone who doesn't have that ability? And so really, I've listed a bunch of people here or different organizations rather, who have classically been a part of those meetings. And all of the voices, if you ever come to our meetings, which we'll talk about in a moment, you'll see that anybody and everybody has a voice. Anybody's willing to speak up, to share their concerns, to have them heard so that we can find a way to advocate for them. And so right now, what we're really focused on and what I most stress about is that there are only a handful of agencies that have been consistently able to provide or willing to provide pediatric hospice services. And what my message to them has been is, we think maybe 2% of all deaths that happen in the country are a child. If we think about that for a moment, 2% of all people that die in a year, I'm asking one hospice agency one time to step up and help us. And so what we're doing is we're trying to touch on those points that were just recently raised. Why are you so worried? What is the barrier to getting this done? And what we find is that there's a fear of working with children, right? That's fair. Children are scary. My old 7-year-old is, right? We understand that people don't feel comfortable working with children, that we don't have the knowledge, right? Like I can tell you what the dose of Tylenol is. I can tell you what the dose of morphine is, but it's different when I just have to remember a number versus a range. And how do I apply that range and what's the maximum number and what's your weight? And I didn't learn that as an internist or a family medicine provider. We also know that concurrent care billing is challenging. And with these, we understand that prognosis is exceptionally difficult to nail down, right? Children are resilient. I often tell families when someone says, well, we're stopping this thing, how long do we have? I'll say, well, I don't know. Children weren't born to read. They didn't read the book, right? And so because we don't know, we're going to do our best. But when you tell me, oh, this patient has Roland-Desbois segmental dysplasia, I'll say, what? When they say, what does that mean for their life? I'll say, I don't know. They'll say, you're the pediatrician. I'll say, cool. I don't know and you don't know, but let's work together. Because I can tell you as someone who did adult palliative medicine for 1.5 years in COVID, because I was the only person credentialed at the hospital who, for palliative medicine, wasn't already on the team, I would regularly walk into a room for a 26-week preemie, and then an hour later I'm with an 80-year-old. And I didn't know what I was doing in the 80-year-old room. Their diapers are bigger, their urine smells different, but we're going to do it together, right? Because it's not about what we know, it's actually about just showing up. I think what we all know in this room inherently is what we do, people say is special, but what we do is we show up. I was going to say a quote, so I'll channel Dr. Dahlberg's. My favorite quote is that our gift as clinicians is that we are able to bear witness to suffering. We're invited to the moments that people don't want to share. And so our job as the coalition is to find ways to reach the people who feel the most fearful. And so we start by having our meetings quarterly, and they are about as casual as we're talking now. We try to laugh, we try to have fun, we try to have every single voice heard. And so if you show up, which I would encourage, these are our meetings. Thank you, Ara, for all your hard work. That you will be asked, Paige, of anything you want to say. You don't have to have a camera on, you don't actually have to talk. But please, we would invite you to come by and share your perspectives. Tell us what you are working on. Let me know how I can help. I don't know how I can help, but I'm going to try. So if you let me know, I'll see what I can do. Right now, what we are doing is we are working on webinars. So 2 webinars per year the past 2 years, if I counted it right. We have done or are planning more webinars in the fall. Jody recently presented at the MNHPC conference on the last day. Our recent topics were focused on trying to address those exact barriers. So we did a talk that was over 2 series on how do we provide children hospice care through concurrent care. We've talked about pain management, and we try to generalize it. What about people who have just neurologic impairment in general? If there is a topic that you would say, the people that I work with would need to hear this. So, man, I want more information. Let me know. I am happy to give a talk or happy to talk to anybody in any program about anything that we could do. Next, we're trying to work on advocacy. And so, I heard the last presenter talk, and I'm going to be chatting with her at the end of the day, trying to figure out how I can coordinate with the national organizations to advocate at the state level. And recently, we have been trying to engage regional partners, not just Iowa, but the Dakotas, Wisconsin. What are they doing, and how can we work together to service these communities? And so I'll just share, lastly, my contact information. And the one final thing that I'll say that was taught to me, how the things that we do for our children and our patients are important, but they are not our story. This is our story. Well, it's mine. Y'all can share, but this is my story. And so if we always remember what our story is, it'll give us hopefully the strength to show up in the future. And I appreciate y'all's time.